You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, Digital Content Editor of the Journal of Addiction Medicine. Today we are joined by Leo Beletsky. He is an Associate Professor of Law and Health Sciences at Northeastern University and a substance use policy researcher. Welcome to the podcast today. I'd like to start by asking you about how you came to focus on this area, specifically the substance use policy.
So my background is at the intersection of law and public health policies. My focus is on substance use and its related harms, so transmission of HIV, HCV, criminal justice issues. And I've been working in this field for about 15 years. Really predating the current opioid crisis, and have had the unfortunate position of kind of watching the issue that I've been focusing on and working on go from being kind of an obscure, urban health, primarily urban health, very sort of, vulnerable population focused area to being truly a national public health emergency. So that's been very disheartening to watch.
I can imagine. And you just mentioned that connection between HIV and substance use. And I feel like you also kind of drew that connection in your piece, that the response to the HIV crisis was this cascade of care model, and you draw some connection to how maybe we can address the substance use crisis with a similar model.
Yeah, I can't really claim ownership of that idea. That's an idea that's been floated by a lot of different folks, including the piece that I cite is in Health Affairs by Robin Williams and colleagues out of New York Psychiatric Institute. But the parallel is important because in many ways, substance use and HIV are both, highly stigmatized, and many providers are not terribly motivated to care for people who have those conditions. And we've had a lot of success in integrating HIV diagnosis and care into primary care settings. We've come a long way from, the early 90s, especially when it was becoming a much more widespread problem, and folks were not able to access care, to now where a lot of primary care settings are in fact well equipped to care for people with HIV. So in many ways, this offers a model by which we can make that transition with substance use care, which I'm sure many listeners are aware, that care is highly isolated and lacking in scope and in there's many barriers, from clinician training to coverage to other kinds of barriers. So the HIV case study offers a useful and hopeful model for how to proceed on the path to integrating substance use care into primary care settings.
Now, your piece was a commentary on this Julie Donahue article, and I just wanted to hear your perspective. Well, why did you decide to comment on this article specifically? And what kind of takeaway messages do you think clinicians can glean from both her article, but also from your commentary?
The Donahue article was really important and interesting sort of window onto current efforts to improve that integration that we just spoke about. The imperative to integrate substance use care into primary care settings has been well documented, and so the question is, how do we do it? And one of the ways that has been floated and is, kind of reflecting on current efforts to change healthcare practice in general, to reform it through financial incentives. And so Donahue and colleagues are assessing the impact of alternative quality contracts, which are basically incentive mechanisms that are designed to shift how providers, what services providers offer, kind of a, nudging mechanism to try to get providers to behave differently. And the piece is interesting in that it actually doesn't test a direct incentive mechanism, but kind of an indirect incentive mechanism to see if there's basically like a spillover effect from other kinds of. So the incentives are not directly focused on substance use care integration. The fact that they kind of found a null result, in other words, that financial incentives did not have this desired outcome, it echoes previous findings that where folks have done similar kinds of studies and have so far found that modest financial incentives or indirect financial incentives are not do not appear to be sufficient in nudging providers to offer more substance use services in their practice. And this is an important empirical basis for kind of with important policy implications, because financial incentives are a go-to tool and a tool that a lot of folks have sort of posited and assumed might work in this sphere, but so far the empirical data demonstrate that they may be useful, but they're definitely not sufficient in actually changing provider practice.
Now, as someone, and this might be our final question, but as someone who is involved in this space of law and policy, where do you see it going in the future? What do you see in terms of trends for the future of substance use disorder policy?
Well, to focus it specifically on this issue of care integration, I think that in the article, I outline a number of things that I think are important sort of elements in helping providers make the choice to provide substance use treatment and other services as part of their primary care practice. Right now, a lot of elements are aligned against that choice, including things like stigma and, kind of prejudice against people with substance use disorder, which definitely needs to be addressed and is definitely part of that choice architecture. But beyond that, there are numerous factors like, insurance structure. So like having to get pre-authorization, things like regulation of, especially in office settings, regulation of buprenorphine prescribing for maintenance treatment is oftentimes something that subjects providers to a lot of audits, enforcement actions, and other kinds of scrutiny by regulatory authorities that honestly, scares people and pushes people away from engaging in this life-saving care. And relatedly, the introduction of prescription drug monitoring programs, I think, also can provide a chilling effect because providers feel like, there's a lot of regulatory and law enforcement surveillance as far as their behavior is concerned. And so they worry that engaging with substance users will expose them to additional risk. In other words, the factors that affect those decisions are diverse, and in some ways they have to deal with policy and enforcement, and in other elements they also have to deal with people's perceptions, and so you have to address both the policy and how providers perceive those policies and how they apply to their practice and their level of risk.
Well, I really enjoyed getting to hear both the policy side of it and even the economic side of it, because it's something I feel like I haven't heard before, and maybe it's something that we should be thinking about as clinicians. So I really appreciate you taking the time out of your day to come and be a part of the podcast.
Yeah, thanks so much for having me and for shining a light on this important issue.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.